Just give a brief history and we'll start with the imaging.
Yeah, actually, we had a 23-year-old female who presented in terms of dysuria, burning micturition, hematuria, flank pain for last 4 months. Was evaluated at the local hospital, and then based on some preliminary findings, she was diagnosed with pyonephrosis and was started on AKT. And then she was referred. She came to our hospital, where upon evaluation, she was examined, and with her basic findings, she was found to have features of GUTB, and that was the discussion till the last class. So the CT images are here. So this is to be discussed in the next today.
Good morning, sir.
So,
sir, this is plain CT domain. In this we can see the right kidney is normal in shape, size and contour. There is no any. Hello, sir. The right kidney is normal in shape, size and contour. There is no any abnormalities in the right kidney. In the left kidney, sir, the kidney seems to be bulky with some irregular contour in the left kidney. And sir, there is calcial dilatation seen in the left kidney.
Prabhu, volume is very low. At max volume, I can hardly hear you. Okay, you guys continue. I'll follow the discussion.
In the left kidney, we can see some calcial dilatation. In the left kidney, we can see some perinephric hypodense lesion. Seems to be likely some perinephric collection. These perinephric collection seems to be extravasating through the perirenal fascia. And sir, in the left kidney lower pole,
you don't say extravasating, extending into the perirenal area. Only when you inject contrast and find it going out on an RGP, then it is an extravasation. Otherwise, it's extension.
Yes, the perirenal collection seems to be extending to the perirenal fascia. And sir, in the left kidney lower pole seems to be also distorted. Some collection in that area also. Next slide. In this contrast film, the right kidney is normal shape size. In the left kidney, sir, the kidney is large in size. The fascia seems to be thickened. The perirenal fascia seems to be both the anterior and posterior renal fascia seems to be thickened. There is calcial dilatation. There's some echogenic area in between the calyces. Seems to be either some contrast stagnation, and there is cortical thinning of the left kidney. The pelvis seems to be there is mild to moderate dilatation in the pelvis. And so there is also perirenal some hypodense lesion seems to be collection. And also in the perihilar region we can see some the echogenic area seems to be either lymph nodes.
See, if you look at this X-ray carefully, you look at the CT scans from the top, you will see on the axial cuts that in the upper poles of the left kidney, you can see even above that there is a hypodense lesion. There are areas which are variegated in their densities around this area. That is in the paravertebral area, in the area of where the diaphragm is. You see the left crust of the diaphragm. And within this, there is a mass of tissue collection inside. It's sort of not describable with clear words, but it is there. And it's a variegated densities in terms of the collection. You see some areas which have got more contrast, more density, some which are less. And then if you go to the next films, you see that this is sort of encased in a thickened capsule. So there is a collection which seems to be encased, and part of it is actually going outside with the paravertebral area under the crust of by the side of the right crust, left crust of the diaphragm. You are not able to see the adrenal gland here very clearly. You should be able to see the adrenal gland. And I find that many people don't actually remark on the status of the adrenal gland. Maybe because it's not seen, but I think you should say it. And then as you come to the cuts, the next cut, you find that suddenly you see something that looks as though it's got contrast in it, and it's surrounded by the same extraneous hypodense area with a collection inside it. And only then, as you go lower down, you begin to see the entirety of the kidney. The kidney itself is not normal. It's absolutely disorganized. There's definite evidence of the kidney is smaller in size. As you say, there's parenchymal thinning. But what is more important is that this collection seems to be around the regions of the upper pole, at the upper cuts. So, you need to be clear that the way you described it got the impression that the entire kidney was surrounded by this. No, it's only a part of the kidney which is, and then this is extending down. And you see a lot of thickening of the perirenal fascia, you see a lot of stranding around it, okay? You see it abutting very close to the posterior abdominal wall. Where you see it, the psoas major is there, and you can see that there is a distinct plane between the psoas major and this kidney there. Okay, so, these are normal anatomical structures. You have to tell us whether you see that there is a space around the kidney in the cuts on the right-hand side. Around the kidney, there is a space. And then can you see the involvement of the pancreas? Is there anything with the tail of the pancreas? These are all normal structures which you are supposed to talk about. All right?
Yes, sir.
You said that the right kidney is normal. You will have to say that the right kidney uptake of contrast. When you see the contrast images, you have to mention the uptake of contrast. The other thing which you said wrongly was there is hydronephrosis of the left kidney. There is no contrast excretion in the pelvic system as of now in these images. So you cannot comment at this point. It's just uptake of contrast right now.
Show some more slides. Show some more cuts here. Some more axial cuts you don't have?
No, sir.
Oh, okay. All right.
So this is a coronal image, sir. The left kidney is totally distorted in its head, and the lower pole seems to be more distorted with hypodense lesion surrounding the kidney and extending into the posterior abdominal wall. The contrast seems to be coming to the pelvic glacial system up to the ureter, sir.
Shubham is discussing, eh?
Yes.
Shubham is a classical situation where the axial cuts are of highly superior nature in terms of interpretation than actually these coronal cuts. The coronal cuts look so much worse than the than what it is in the axial cuts. You see,
Yes.
it looks as though there's nothing there. You see something like the kidney, it looks as though the kidney is split in two and all the rest of it. But it's not.
Yes.
It's not as shall I say, it's not as bad as what these cuts make it out to be. Okay, and you see, I think the reconstructed images are showing more of the vasculature of the bowel than anything else. You see all those vessels which are going down, mesenteric vessels, etc. They're all there, so you're not able to see everything really well. Anyway.
In the black, this is a CT IVU picture, sir. In this, the left kidney is distorted and the contrast coming into the ureter, but in the mid ureter, there is some irregular constriction and dilatation, looks like the beaded ureter, and after that there is a thinning in the there is narrow in the caliber of the ureter. Seems to like mid-ureteric stricture. And bladder seems to be little contracted with some the bladder seems to be contracted with some irregular lesions inside the bladder.
See, unless you have an image where it is written, it is a full bladder film, this may look like a partially distended bladder. You don't say contracted, that's a thimble bladder. But you never know. The radiologist might have taken early images, and unless it is mentioned, it's a full bladder film. You cannot say the bladder is small capacity in IVU.
But sir, the bladder seems to have some irregular, not looking like normal, sir. Partially filled bladder with irregular heterogeneous lesions, sir.
See, the only thing you can really say in this series of images is that whatever is there on the left side is excreting something. All right?
Yes.
It's excreting the contrast, but whatever is inside that contrast material is a totally disorganized mass of PCS.
Yes.
You can't actually see what the upper calyx looks like, what the middle calyx looks like, and the pelvis is not there. So where is all this gone? We have to try to figure out as to what's happened. So there's total destruction here of the PCS.
Yes.
The pelvis has become contracted and is being drawn inside. We are not sure whether this was an intrarenal pelvis, but when you compare it to the opposite side, you see that the pelvis has been completely withdrawn inside.
Yes.
All right, and this is a totally disorganized, sort of destructed calyceal system. And as you said, there is some minimal narrowing of the ureter. It seems to be consistent in three of the images. Whether they're done at the same time, we are not sure. But sometimes, ureteric peristalsis can also look like this. But if you compare it to the other side, then yes, this narrowing is consistent in that mid-ureter. And I think I'd agree with Prabhu that, you can't just say that the bladder is contracted. Contracted means a pathology. Small means it could be just underfilled. What is more important is you look at the outline of the bladder. Is it distorted? You look at whatever surfaces you can see inside. Is that abnormal? And see if there's any filling defect or anything else that looks suspicious inside the bladder.
There is no as such filling defect, but there is heterogeneous cannot make out. It's totally regular.
No, whatever it is, the shape of the bladder is the shape of is a normal shape. At the moment, that's all you can say. and the lining is uniform. There is no irregularity in the lining of the bladder. So there's no filling defect. I don't see any filling defect at all inside the bladder.
Yes.
So when you have a situation like this, you go back to the patient's symptomatology and find out whether the intense frequency or anything they have matches this sort of bladder. Invariably, when the bladder is contracted in TB or any other disease of pathology, the shape of the bladder changes. It becomes more rounded. Okay, it does not retain its ovoid elliptical form as it seems to be in this situation. So,
Yes.
yeah. So you think this is an inflammatory condition or is it a malignant condition?
Sir, it's most like inflammatory conditions.
Inflammatory condition. What evidence do you have to say that this is inflammatory?
Because there is distortion of renal parenchyma with extravasation, with some perirenal hypodense lesion, and there is also the pelvic cell system of the left side is also some little bit distorted.
See, when you are asked a question like, is this an inflammatory condition or not? You have to take the entire clinical picture, the history, the examination, the labs, and the imaging and come to a conclusion and say this is what it is. Just don't focus. We've got all the information now.
Yes.
We know the history of this patient, you know the lab findings, you know now the imaging. So you put all of these together and say on the basis of this, and this imaging feature suggestive of like this is more likely to be an inflammatory condition. Is it more likely to be a malignancy or whatever it is? So don't just focus only on the imaging. Now you got all the information, so you use that.
A patient has a history of flank bend with features of irritated looks, with a few episodes of hematuria 4 months back, and also has a history of fever which was intermittent, low grade, mild, and with evening rise of temperature. And the patient also had a history of local treatment where there was an ultrasound done which showed pyelonephrosis and was declared to be Montu is positive, sir. Based on the above history, sir, along with the lab investigation showing sterile acid pyuria, counts were normal, and the ultrasound done was showing the lower callus dilatation with presence of debris within the calluses, and the CT picture showing the distortion of renal parenchyma with perirenal collection, and distortion of the pelvic cell system with some beaded appearance of the ureter. All this seems to be summarized like an inflammatory condition which is affecting the kidney, the ureter, and the perirenal areas. So seems to be like inflammatory, most probably genitourinary tuberculosis.
Why can't it be non-tuberculous pathology?
The non-tubercular, the lab investigation doesn't.
You can get an identical picture in other inflammatory conditions of the kidney, where there's total disorganization of the PCS, etc. What other inflammatory condition is there in the kidney that can give rise to this sort of a picture?
There could be genitourinary pyelonephritis.
Yes. Yeah, you have to consider XGP in a patient like this.
But there is some stone present in genitourinary.
Sorry?
There is calculus present in genitourinary pyelonephritis.
No, not all the time. While we are usually told that it happens with in patients who do have a calculus disease, it doesn't necessarily mean that there has to be a calculus inside that kidney to have accounted for this. Okay, so you can get it. What is the unusual feature here in this patient's history, which is difficult to explain?
On history, sir.
Yes, history. The history is a little difficult to explain just on the basis of an inflammatory process. Something else has happened here which has accounted for that. Isn't there hematuria here?
Sir, hematuria is there, sir.
Yes. So how many times in a patient who has got inflammatory pathology do they present with hematuria?
Less likely.
That's an important symptom here, which has brought the patient to the hospital. Apart from the pain and the fever, so there's hematuria. You have to explain that hematuria.
So the hematuria could be, sir, due to the electric strictures, sir. There could be a hematuria, sir, or.
No, you have to find out whether this hematuria is, now you have to go back to the clinical history. Is this hematuria with clots or without clots? Is this hematuria painless or painful? You've got to go back to the basic stuff.
Yes.
Now you've got to see whether this hematuria, what is, if it is obviously arising from the kidney, then what could be the mechanism in an inflammatory pathology to give rise to hematuria? In a malignancy, what can give rise to hematuria, isn't it?
Yes, sir.
Yes. Can something else like that happen in inflammatory pathology to give rise to hematuria?
In inflammatory condition, we have papillary necrosis, sir, that could lead to hematuria, sir. And
apart from papillary necrosis, anything else?
The distortion of the parenchyma.
When there is erosion, there is destruction here. Inflammatory destruction also can give rise to hematuria. So the issue is here whether it has been with clots or without clots, etc. Those are the things that you need to find out. Usually this sort of hematuria is mixed with urine. And it can be sometimes quite profuse in these patients. So,
Yes.
What is the report on this patient? What did the radiologist show?
The study revealed enlarged left kidney measuring approx 10.7 into 5 into 4.5 centimeter size, showing irregular contour, asymmetric calyceal dilatation, focal cortical thinning, evidence of distortion of calyces along with large thick enhancing wall collection in the left perirenal space, eccentric thin and thick septa extending superiorly up to left posterior medial subdiaphragmatic region, focally bulging into the thoracic cavity, covering an area of approx 13.4 into 6 into 6.5 centimeter. There is bulging of anterior perineal fascia, posterior perineal fascia with smaller extension into the left posterior perineal space. There is destruction of left perineal fascia measuring 16 mm with extension of collection in relation to tail of pancreas, measuring up to 4.6 into 3.4 into 2 centimeter, focally compressing in the mid part of the splenic vein with few surrounding collaterals. Following IV contrast administration, left kidney shows heterogeneous enhancement. There is evidence of impairment of left renal excretory functions showing stasis of contrast within distorted upper calyces, suggesting narrowing in the calyceal neck. The lower calyx shows communication with pararenal pelvis with slight focal narrowing and distortion. Some of the lower calyx in the lower pole show non-communication with the renal pelvis, suggesting stenosis. There is suboptimal CT nephron pyelographic effect. Subsequent scan after 6 minutes shows some concentration of opacification of left renal collecting system without ureteric visualization by excreting contrast. Delayed scan taken after 40 minutes shows concentration and opacification of excreted contrast within left renal collecting system. The right kidney is normal in CT morphology and shows a normal post-contrast enhancement and excretion of contrast. Right kidney measure 10 into 5 into 4.5 centimeter. Left uretary is regular with irregular outline in beaded appearance with alternate narrowing in contour structure up to a segment of 10 mm. Right uretary is normal in pores, caliber and outline. No internal filling defect. Urinary bladder partially distended with mild wall thickening. no wall irregularity or interlinear disease.
Dr. Mohan is available. I just see a message in the chat box from Mohan.
Yes, sir.
Huh?
There's some audio problems.
Oh, right. Okay.
Yeah, I'm here. I can't hear most of the things, but I'm following.
Right. No, he made a comment that the right ureter is also not entirely normal. I just saw one statement in the chat box. So,
And the colon is loaded right through.
there is only one other condition which also gives rise to such a distorted appearance in the kidney, and that is TCC. I mean, RCC we know usually is a sort of a exophytic or even endophytic rounded well lesion, but TCCs are also terribly dicey like this, and they can have total destruction of the collecting system with hematuria. They can perforate. Everything can happen with the TCC. The point here is that the ureter usually is not involved like this to a large extent with multiple areas of narrowing and stricturing. So that's a giveaway as far as TCC is concerned. But these are the TCC of the kidney is a condition which people tend to forget when you have this. Everybody wants a classical picture all the time, but it can get anything that looks bizarre. So what was done for this patient finally?
Has been drawn medially over the vertebra, if you can see. Right through, it's pulled medially, and in a couple of vertebrae, it's flying over the vertebrae.
So what was done finally? It's the case from...
Yes, sir. Sir, based on all these findings, we had she was already put on AKT, so it was continued, and we decided to plan her for exploration because of this distorted architecture and large perinephrine. We had also taken a consent for nephrectomy intraoperatively. But once we opened up, we found large pockets of perirenal abscess. So initially we did a cystoscopy, and then we planned for open drainage. On cystoscopy, there was quite a bit of oozing out erythematous patches in the bladder, but we could not visualize the bladder wall properly. However, the capacity was less; it was only 200 ml. And then we went for we did a DJ stenting, and then we proceeded for open exploration. On exploration, we large pockets of pus were there which were drained.
Sorry, can I interrupt? When you did the DJ stenting, did you do an RGP? You have some images of that RGP? Or you just put the stent in?
Just put the stenting with difficulty. Actually, it was...
you should have done an RGP. You should have done some imaging of that ureter to confirm the findings of the stricturing in the ureter. You would have been able to see the PCS in a better way.
Yes.
I think Mohan has remarked some time back that the RGP seems to be taking a back seat in many situations. It's a very good imaging. It's a very good X-ray to see, When you know what the collecting system looks like. You can confirm most of these findings that you have seen. It's important. For not only for understanding, but for your records, isn't it? You're saying now that you put the left DJ stent with difficulty. Was that because there was a narrowing in the ureter, or was there something else? You had technical difficulty or what? So anyway.
Intraoperatively, once we drained all the pus, we found that there was renal parenchyma, but tissue was there. So we decided to just go for drainage of abscess and keep the kidney. And we kept that drain. And gradually, postoperatively, immediate postoperatively, till preoperatively, the patient was having recurrent bouts of fever and pain. And postoperatively, within 2-3 days, all her pain and fever had subsided. And the pus was there, which was continuing to come in the drain. So the patient is kept on a perinephric drain for some time, and she is on follow-up. So currently her symptoms of dysuria and all are improving and recovering. She is not having any bouts of fever. She is currently on the AKT. So we are following up the patient. Right
How
now.
much is coming in the drain every day? She must have gone home with the drain. Has she gone home with the drainage too?
Yeah, it is coming through the drainage tube, but it is decreasing. Quantity is decreasing.
Has she gone home or she's still in hospital?
No, she has gone home. We have discharged her. And she is on follow-up. So on follow-up, we are deciding what to do actually. But the only positive thing is that she has recovered from all her symptoms. She is gaining weight slowly. Fever and other constitutional symptoms are improving. So,
have you heard of an operation called cavernotomy?
Sir?
Have you heard of an operation called cavernotomy?
No, sir.
Since we are talking about tuberculosis, I'm asking.
Okay.
Anybody? Cavernostomy. Cavernostomy. No?
No, sir.
No, sir.
This is a operation that is done specifically in patients who've got tuberculosis where there is infundibular stenosis, which has to be proved. And then either a calyx or that particular segment of the kidney which is related to that infundibular nerve blows up and forms a perinephric abscess and collection. And all you do is to drain that and then sort of marsupialize the collecting the ruptured kidney, just like marsupializing any cyst. The most important thing is you've got to be sure that there is no communication with the PCS, otherwise you will land up with a urinary fistula. So this invariably is in TB, and that part of the kidney that is related to this infundibulum is non-functioning. So it doesn't actually produce urine from there, but if there is no infundibular narrowing, then the kidney will produce urine from the other parts and come leaking out. So you've got to be 100% certain. So this was an operation, very useful operation that used to be done for this. So you preserve the kidney, take off all this pus, and leave the kidney there and treat this patient. So it's there in the book. So very rarely done these days, but I have done 2 or 3 of these myself. It is very difficult to get the ideal case. Most of the time, you have total destruction of the kidney, or you've got to do some repair work as far as reconstruction is concerned. Yes, tuberculous cavity-like thing there inside.
Shubham, what do you tend to do with the stent now that you have placed? How long you want to do? Keep the stent in place, exchange the stents. What is your thought about the presence of stent in G tuberculosis? Is it therapeutic or it's just buying time?
The stent placement should be there for the intensive course of AKT treatment since 2 months, because most of the fibrotic process occurs in that phase only. So in order to prevent any further stricture in the ureter, we should put a stent so that there is a passive dilatation of ureter, and the kidney there is some drainage also. So we should put the stent for 2 months, and we should do a regular follow-up to see whether there is any further ongoing disease process or not. And if the ongoing disease process is not there, we can remove the stent after 2 months.
See, if the tubercular inflammation is only mucosal, then it will resolve with the stent. If it is span wall, whether you keep it for 2 months or 6 months or 1 year, the stricture will be dense and you need to reconstruct. This is not a stone disease where you keep a stent after the surgery. In tuberculosis, you need to understand what's happening in the pathophysiology. The presence of stent is only to cover the patient with the intensive phase of therapy, and you plan reconstruction only usually after at least 4 to 6 weeks of antitubercular treatment. So that is to buy some time. If a stricture in tuberculosis is formed, it is formed. Your stent will not make much difference unless I said it's only a mucosal one, it has resolved.
Actually, in most of the situations, the stent is put there probably to just protect the kidney, especially the opposite side, which is apparently normal. When you start treatment, when one kidney is gone, then the other side, in the process, it is a bilateral disease. It's just that one side seems to be more affected than the other. But in certain situations, you may find very subtly, you will find that the lower end of the ureter on the which apparently normal side, does have some degree of narrowing or mild dilatation. This is all telltale signs, and therefore very careful scrutiny of the images is necessary. So in that situation, as Prabhu said, you put a stent on the side which looks normal to you so that it will protect the kidney function and you won't land up with anuria or worsening situation. That is probably just, as you said, mucosal. But once it hits the wall, tuberculosis is a dirty disease. That's all there is to it. And the ureter is not a very robust piece of tissue there. It's amazing how it takes so much of beating.
When we started with stents, that was the purpose, to protect the good kidney. Somehow it got extended into all situations.
Protecting the lousy, shitty kidney.
Sir, one question, sir.
Yeah.
Sir, should we put a chest tube in this patient, sir? Because the penineptic collection was seemed to be extending to the thoracic cavity. Should we put a chest tube practically?
Well, that's a decision you've got to make intraoperative. That means it has gone through the hiatus in the diaphragm into the chest. But there was no pleural effusion as such there.
Things appeared clear.
So, you can just put a whiteboard drain, it should drain, that's all. Unless you have opened the chest during the process and you find that, I may not be able to close the thing properly, the diaphragm properly, and this patient in the post-op period could have a collection. That's an intraoperative decision which you as a surgeon will have to make.
Usually, when we place a drain, whatever fluid or anything there drains out of this because the chest is higher than the abdomen. And drainage always takes place through the point of maximum or minimum pressure. Wherever the pressure is the lowest, that's where it will drain. So when placing the abdominal tube, very rarely have we found a need to place one in the chest also. Usually it drains out. If there has been a way for it to go up, the same path will allow it to come down, unless there is a localization.
Didn't this patient also have a past history of pulmonary coughs?
No, sir.
No.
Shubham, let's say this patient has cough and you do a sputum AFP which is positive. So you have urine AFP positive, you have sputum AFP positive. Is there a change in the regime or the regime is the same?
The regime is the same, sir, at one.
You are wrong. So when you have two systems involving, they say it is multi-system and the treatment is 3 + 9 months. We had recently a case, so I'm just telling you. I spoke to the pulmonologist, so she said if it's one system involving, it is for 6 months. But if it is multisystemic, miliary type, then your regime is for 1 year.
Yes, sir. Yes.
There is, the NTCP guidelines are very good in this. I think you should read them up. One system not adjacent but distant. Previous tuberculosis, reinfection at another site. So if you read that, you'll get a lot of this information. Just a point, miliary tuberculosis is not multisystem. Miliary tuberculosis is specifically a term given to the miliaria which are seen in the lungs, the specks of white which we see distributed all over the lungs. Otherwise, it's known as systemic tuberculosis or multisystem tuberculosis.
Shubham, what do you think the present regime is? Alternate day regime or daily regime?
It's a daily regime.
Yeah, the alternate one has been given up. Now, in the intensive phase, there are 4 drugs. What about in the continuation phase? How many drugs now?
Two drugs.
Very good. 3 it is. I just wanted to know whether you updated yourself. It is 3 drugs in the maintenance phase. It is not 2 drugs. That is old.
How are you treating this patient? What is the way to treat this patient apart from giving them anti-TB drugs? What is Dispur doing? I know you send this patient off with a drainage tube. But what is the recommendation for this patient, how to treat them with the TB drugs or the regime?
So right now she is on intensive phase only.
How do you know? How do you know she's taking the medication?
We are taking a daily update and also the color.
She's with you in the ward?
Sir?
Is she in the ward with you?
She is not in the ward, but the family keeps giving updates every week, sir.
Who gives the update?
To ours, they were in contact with us actually. So they are taking the drugs. They have taken all the drugs with them, and they are regularly following that as prescribed, sir.
What is the recommendation of the government of India? You have to ensure that the medication is being taken under a supervised situation. So these patients must be referred to the local DOTS clinic.
Yes.
Yes. They are the people who will decide as to, and it's very important.
Okay.
We have to be responsible to make sure that our patients are categorized. At the same time, the government logs in, because all this information is very important for them to make the next guidelines.
Yes.
So, I'll tell you the commonest thing is for us to treat the patient because the drugs are available off the counter. But no, I think if you tell them, these are all given free,
Yes, sir.
You get free. You go to the DOTS clinic, somebody will be there, they'll give it to you, give the report, everything, it's done pakka. I mean, for a country of our size, it's a very impressive scheme, I'll tell you. And you can get them. You can call them. You've got numbers of these people, and I've spoken to 2 or 3 people here locally also. And they seem very committed guys to make sure that the patient actually has the treatment. Give it free. Anyway.
Okay, sir.
Ultimately, this patient probably will come back for an effect.
Doesn't look too good.
This kidney is not worth its weight in anything. You may treat the patient with all the medication. It will be interesting to see how it comes back after 6 months and what its functional status is and everything else.
Actually, before sending her, that was not put up. Before sending her home, we did a screening CT IVU that had shown that her kidney function was better and improving, and it was similar in comparison to the right kidney. The only thing was the presence of a resolving paranephric collection. That's why the drain has been kept there. But the problem is related to the drain, continuous draining which is there. But in comparison to previous function, the function is seen to be significantly improved. That is why we are actually confounded to go for removing the kidney actually. Because on one side the function has significantly returned, but on the other side, probably there may be a little bit of extravasation, and moreover due to tuberculosis, it is taking time to heal. So because of the continuous extra-abdominal drainage that is coming, so we want to buy some time before making a next decision.
Very good. I'll be very happy to know what finally happens to this kidney.
Yes, that's what we are also confounded. We want to save our kidney because it's the function is returned, but because probably some fistulas communication, so that's what is confounding me. If the fistula persists to be there, then maybe we have to end up removing the kidney, and we have counseled the family in that manner also.
No, is it urine or is it pus, as you said?
It is urine also, because we have observed the drain is typically that orange color, which is seen during EKT. So,
how will you
No,
confirm
orange
whether it is
color
urine?
can come even in tears. Okay. Any body fluid which has rifampicin will give orange color.
okay, sir.
So don't just go by that.
Okay,
You must
sir.
be able to demonstrate a fistula. Probably do an RGP for that.
Yes.
Or RGP followed by a CT so that you can get the final details.
The biggest challenge is going to be if this kidney, as he says, is showing some function, and there is a persistent urinary fistula, then you will be bound to try to correct this by removing that portion of the kidney probably which is there. From where this fistula is coming. That to reconstruct, and then that will be a major decision.
Yes.
So in most of these situations, the kidney dialysis is taken and thrown in the bucket. The problem arises if it is a single kidney. If it is a single kidney, then you are hell bent to actually preserve it for whatever reason. So therefore, that becomes a more difficult challenge in TB.
Okay, sir.
But there is no doubt that the maximum number of operations done for tuberculosis is actually an effectiveness. The number of reconstructive procedures that are done on the kidney for TB are far fewer in number than an effectiveness. Augmentation, yes. We are not talking of bladder augmentation. I'm talking of renal preservation. So
Yes, sir.
that's one of the main problems with TB.
The simple test would be to send the drain fluid for creatinine.
Yes.
And then if it is urine, then you proceed with RGP as said.
Yes, sir.
Anyway. Okay. Any other queries? Prabhu, anything else?
Nothing, sir. Thank you.
Thank you. Thank you, sir.
Okay, then, thank you to all. We'll meet next week, hopefully with another interesting case.
Thanks.
This is good. Bye, folks.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Right.
Well,